Good evening and welcome to the Brian Crombie Radio Hour on Saga 960. Obviously, COVID-19 and the current pandemic that we're in has been the number one topic all of us have been focused on for the last couple of months. And I wanted to bring on our show Ross Upshur. He is the Dalla Lana Chair in Clinical Public Health, the head of the Division of Clinical Public Health at the School of Public Health at the University of Toronto. Really pleased to have you here with us today, sir. How are you?
Yes, I'm very well. Thanks for the opportunity to join you on your show. It's a great pleasure.
It's our honor. So are we ever going to get out of this? What's going on?
Well, that's a very good question. One of the difficult things when you're in the midst of an outbreak of the kind of complexity that this SARS-CoV-2 outbreak has is people want to will it away, but you can't wish away a pandemic. It has its own inner logic, and we're going to be, I think we're going to be in it for at least another year, to be quite honest, because there are so many ramifications, and it's the hard fact for people to accept is that still about 98% of the population remains vulnerable to the virus. So
because they have not got infected.
Yeah, that's correct. So, seroprevalence studies in Ontario indicate that, less than 2% of the population has been exposed. And even in places where there's been quite a lot of COVID activity, there's probably still 95% of population vulnerable.
And so the 1 year estimate is because that's how long you think it's going to take to have a vaccine and a vaccine that is immunized widely enough?
I think there's three key elements. The vaccine is one of them, clearly, but the vaccine alone will not bring an end to the pandemic. I think we need to be much more strategic about our testing policies and testing, contact tracing, and follow-up. And I think we'll see some real improvements there with possibility of new testing strategies like saliva-based tests. And I think people will finally come around to really internalizing the need for self-protective measures such as mask wearing, hand washing, and social distancing. I think we've done a very good job of it in certain parts of the world, and other parts of the world it's remained contentious. And as a pandemic, it is a global phenomenon, so it's something that affects everybody, and we need everybody around the world to be on the same page to really be successful in bringing it to an end.
So let me challenge you there if I could. I've been hearing so many people of late that are just tired of social distancing, physical distancing, objections to wearing the mask, etc. Just walking around Toronto or around town, in restaurants and elsewhere, you see a lot of people that aren't doing the things that you're suggesting that we need to do. So have we just grown tired of this?
Yeah, I understand that. I mean, and it was one of, I think, something that we've all been concerned about. That's people will get fatigued, obviously. It's been very challenging and demanding for us all. It's disrupted every facet of our life. But it really will require, the attention to hand washing. We're going to have to behave ourselves. So we'll get tired, and then we'll start to see a recrudescence of cases. A good case in point is what's happened, for example, in Australia. They looked like they had it under control, and the state of Victoria went back into lockdown. So if you start to see other jurisdictions going back to previous ways that we've been managing the epidemic, it sort of gives you an incentive to take care of yourself and do the self-protective and other protective activities that we need to do, even if we're tired, right? We've got to keep consistent, and we have to stay with it.
What do you think of Sweden's strategy of just letting the virus go wild and try to achieve herd immunity?
Well, it didn't work out too well. So they had neither the public health nor the economic benefits that were supposed to be associated with that strategy. And their seroprevalence is nowhere close to anything that would look like herd immunity.
What would their prevalence be at?
I think if I recall, I'm speaking off the top of my head, it was somewhere only around 5 to 6%. So that still leaves 94% of the population non-immune. And
we're chatting tonight with Ross Upshur, who is the chair in clinical public health at the University of Toronto. We're going to take a break for some messages and come back more on COVID-19 and the pandemic in just a minute. Stay with us. Welcome back to the Brian Crombie Radio Hour on Saga 960. We're chatting with an expert in pandemics. He's the chair of clinical public health at the University of Toronto. His name is Ross, I presume Dr. Ross Upshur, but you don't have a doctor here, so I presume a PhD. Tell us a little bit. What's
No, I'm actually a medical doctor.
Medical doctor, okay, yeah, even better than a PhD.
Specialist in, well, no, that my family would disagree.
Okay.
My wife has a PhD, and my kids always tease me and say that she's the real doctor. So
give us, if you could, just a little bit about your background. How did you come to be where you are?
So it's a longer story because I'm an older man, but I started out as a philosopher before I went into medicine at McMaster. I was a rural family physician in Southern Ontario for 7 years, got interested in public health, and then I returned to the University of Toronto where I did the specialty training in public health medicine and a degree in epidemiology. So I've been affiliated with the University of Toronto since the mid-90s. I'm a professor now. I've had an active career as a family physician and a public health physician. I've been a researcher, and I've been working on epidemics and pandemics because my area of interest in public health was in epidemiology and infectious disease control. My thesis was on actually mathematically modeling the health impacts of influenza virus. During SARS, I was seconded away from my role as a physician at Sunnybrook to York Region in public health, where I became involved in quarantine efforts during the 2003 outbreak. After that, I started to take the ethics of pandemics and epidemic control very seriously. And since then, I've worked with the World Health Organization and other organizations, Public Health Agency of Canada, with a particular focus on the ethical dimensions of epidemics. So I've helped write some of the global guidance documents in pandemic influenza, on epidemic disease control. And I'm currently the co-chair of the WHO's working group on ethical issues in COVID-19. So I've been doing a lot of this for a very long time.
What are the ethical issues?
So there's kind of a playbook. And if you go back to when the virus first emerged out of Wuhan, the first issue was, oh my God, how are we going to actually manage this? So the first ethical issues usually resort to the legitimacy of the use of restrictive measures such as quarantine and isolation for the control of an epidemic disease. These raise obvious concerns for civil liberties, restriction of movement. So we went through that in 2003 in SARS. So the question is, when is it legitimate to restrict, taken for granted, or constitutionally enshrined liberties such as freedom of movement? And so you can say you have the law behind you, but you actually need an ethical justification. There has to be a particular harm associated with it. It has to have community spread. You need to use the least restrictive measures to achieve public health goals. The reciprocity condition, that is what you're going to do for people who are putting themselves under quarantine and isolation in order to achieve public health goals, need to be articulated. And then you have the whole set of issues about how decisions are made, who has a stake in them, how they're communicated, whether they're appealable or not. So the issues around restrictive measures come up first. Then, of course, you have a new disease, which means you're going to have to do research. So there's a series of issues around research ethics that need to be navigated. And those fall under those were the first set of documents that we wrote for the World Health Organization. Is it required, or is it legitimate to take, say, shortcuts in some of the usual ethical oversights in research because of the pandemic? Our argument was no. Actually, you need to maintain all of the protections for human subjects during research during COVID. So there's the research ethics. Then as the epidemic evolves, there starts to be questions about what are the limits to a healthcare provider's, a physician's duty to care, because you start to notice, and this happened very early on in Wuhan as well, that the people who start to get sick are the patients, but also the people who provide care to the patients. So what are the limits to the duty to care? And the sort of this days between SARS and the H1N1 pandemic in 2009, I chaired a working group on health workers' obligations in pandemics. So we can talk about that. And then finally, you get to issues around scarcity. So then we saw that again in Wuhan and in Italy, where systems start to become overwhelmed. You have more patients than you have resources, so there's shortages of drugs, of ventilators, and how do you go about fairly allocating those resources? Then when it comes to the response, some of the work that we're doing now is how do you set priorities for who's going to receive a vaccine or a drug when they become available. So you can see there's a whole set of ethical issues that are intertwined in almost any pandemic of major significance. We saw this with Zika, with Ebola, with H1N1, and with SARS in 2003.
We seem to have had reasonably good following of the guidelines and the rules in Canada, but not in the United States necessarily, and pockets of opposition to freedom over control by government in regards to social distancing, physical distancing, and also in regards to masks. What do you think about that? Is there any real justification for that? Is that just people that are being a little bit selfish?
Well, I think there's different political and social traditions. I remember after SARS, we did a nice study in SARS where we asked people about their attitudes towards quarantine. And actually, this is the 2003 outbreak. And we did a further study about public opinion towards quarantine. And Canadians take it very seriously. So they saw violating a quarantine order. We asked them, is it like, not paying a parking ticket, running a stop sign, physical assault or manslaughter? And to our surprise, in a random survey of Canadians, they were more akin. It was about 60–70% thought it was that violating a quarantine order was more closely associated with assault or manslaughter. So Canadians have a more community focus, peace, order, and good government versus, life, liberty, and the pursuit of happiness. So libertarian ideas or preservation of liberty as the highest value is very prominent in the American mindset. And when I presented the data that we had collected on quarantine and adherence to quarantine, on following government orders in a meeting at the United States, my American colleagues were aghast. They couldn't believe how community-minded Canadians were. So I think it's just very different political traditions. And of course, you have to have a belief in a common good and the community and community health having standing as something to value and something to work towards achieving to be able to have this kind of concerted effort. If your idea is that self-interest in your own liberty trumps, no pun intended, every other particular value, you're going to end up with the situation that you have south of the border.
The biggest tragedy, I would think, has been long-term care. What went wrong there?
So I think a couple of things. One is that, and I'll be fairly frank here, we got caught up with curve flattening, and I think that was appropriate. And it was a bit of meme science in my view, because remember, there was the two curves, what would happen, and then if you flattened the curve, and the hatched line was health system capacity. And so we got concerned about preserving acute care resources, not thinking through the logic that if you move everything into the community to preserve acute care and intensive care beds, that the brunt of the epidemic is going to play out in the community. So I think that's where we got a bit trapped. I don't think that we put up enough defenses around long-term care facilities. I think we underestimated how severe the virus is when it transmits amongst vulnerable people in congregate living. So once bitten, I think that we really need to redouble our efforts in anticipation of a second wave at ensuring that we have maximally protected those populations. And again, simple things like, it's not simple because it's hard. We know this from years of studying hand hygiene in acute care and in hospitals. people don't like to wash their hands. And, the simple matter of attending to hand hygiene has a significant impact on reducing risk of transmission of infectious diseases. So if we adhere to very good, rigorous infection prevention and control methods, which are tried and true, well-established, very deeply evidence-based, we can do our best to protect vulnerable populations like long-term care facilities.
I've been hearing a lot about sort of other than respiratory impacts of COVID-19, both from a vascular standpoint as well as from a cognitive standpoint. Are you concerned with anything of those in those areas?
Well, to be honest, I'm concerned about virtually every dimension of this pandemic, because it has been it's been a pandemic of all facets, in the sense that it's not simply behaving like a respiratory virus. It's actually had dramatic impacts on people who have multimorbidity. It has tremendous impacts on people's psychological well-being because of the consequences. And of course, the social and economic consequences have been staggering. So this is far and above, I think, what anybody had anticipated a pandemic was going to do to societies, cultures, communities, and economies globally. This has been a very significant and dangerous pandemic, and we're not out of it yet. And I fear that we're only starting to see some of the collateral issues and how they may play out, because governments can't continue; they can't print money, and we need a revenue base in order to be able to afford all of this.
In the Spanish flu of 1919. I understand the second wave was more lethal than the first wave. What is your expectation this time?
Well, I'm hoping that we are better prepared. I think that unlike 1919, we do have very advanced biotechnology. We do have personal protective equipment, which wasn't you had hand washing, you had hygiene, but we didn't have the sorts of tools at our disposal that we have now. So I'm thinking that we've had time to prepare and think through. We know it's out there. We know a second wave is possible. We do have some evidence of effective therapies for people who become quite ill. We know that steroids help. Dexamethasone is effective. Remdesivir has some effect. There's clinical trials ongoing to test new agents so that can sort of blunt the mortality of those who become very ill. So I'm hoping that if there is a second wave, we're able to manage it much better than the first one.
There's been some talk, I understand, about people that have got the virus once being reinfected, and so therefore not building up immunity. What's your expectation there?
Well, I think that's, I've looked at those studies, and I think it's a real phenomenon. I think that's something that we need to be very carefully studying. And one of the issues that is live is how long immunity lasts. Clearly, you can get reinfected, but that would really make for a very dangerous situation if there were high rates of reinfection. Right now, there's only been episodic cases. The other thing we don't know is whether infection with COVID confers immunity, and if that immunity has substantial duration. So one of the challenging factors of a novel virus is the lack of long-term knowledge about many of the consequences. We're going to have to learn to live with a certain amount of uncertainty and to take concerted steps, accepting a certain amount of risk, because there's no other way to reason or act or deal with the problems.
My last question. Some people say that this has been a complete surprise, and other people say, no, we've been expecting it. There were movies about it, there were books about it, there were TED Talks about it. People like you that are the experts in it, what's your sense? Should we have been expecting this at some point in time, and did we not plan well enough, or were people like you not listened to?
Absolutely. I think we should have been prepared for this and prepared better. So I like to say since 2003, we've had 7 major epidemics. We've had 3 coronaviruses, 2 Ebola outbreaks, global pandemic influenza, and Zika. 4 of those were public health emergencies of international concern. Since the early 90s, when the Institute of Medicine released what was called emerging and re-emerging viruses, it has been well known in the public health and infectious disease community that we should anticipate a fairly significant pandemic. We were looking towards influenza viruses, but we happened to get a coronavirus. That's part of the reason why we've created the Institute with a lovely donation from the Vora Miller Foundation, is to really mobilize our knowledge resources so that we can actually perform better going forward, that we will have health professionals, policymakers better trained, because this is a bad one, but there are still nasty ones out there. There's thousands of uncatalogued viruses. If we're not going to put our efforts to being better prepared, we're in real trouble.
Ross Upshur, Chair of Public Health at the University of Toronto, thank you so much for joining us tonight on the Brian Crombie Radio Hour.
Thank you for your time. I greatly appreciate the opportunity to speak with you and wish you and your listeners good health and safety.
Our pleasure. Thank you.